Okay, I'm back, but it's not letting me update the software, of course. Let me see if I can record from here.
Debbie, I was able to get my Fathom to join once I could sign in successfully. So I've got that running, if that's helpful, and that will record.
Oh, does it actually record the session?
Yeah, it
Cool.
does. I can
I
send it to you.
may have the option to record to the cloud, so it'll be good. We'll have redundancy. So, okay, let's see if this works.
This meeting is being recorded.
Sounds like it got working. So, thank you everyone for bearing with me this morning. Welcome to the April Survivorship Lecture Series. This morning, we have Kelsey Lau, who is a board-certified physical medicine and rehab physician who completed residency at the University of Texas Southwestern and an oncology rehabilitation fellowship at the University of Michigan. She now serves in multiple roles, including Chief Medical Officer at FU Cancer, a supportive care digital application for health. Kelsey is a former competitive soccer player and has over 4 years of phase 1 to 3 clinical research experience, including 2 years of work at the Fred Hutchinson Cancer Research Center. Today, she will discuss the use of digital health tools in enhancing cancer survivorship care outcomes. So, Kelsey, um, if you can hear me, go ahead
Yeah.
whenever you're ready.
Okay. Let me see if I can share my slides here. Another step in this whole process.
We'll get this.
All right. Can you see the slides full screen?
Yeah.
Looks good?
Uh-huh.
Okay. Let me just alter my screen here just a second. Okay. All right. Okay. Thank you for having me today. I'll give you a little bit of background as well in terms of why I'm giving this talk, and how I got into this arena. So, as a practicing physician, I started to feel the frustrations of not being able to offer my patients the resources and the services that I felt like they deserved. And so I ended up taking an AI class, and then I completed a fellowship in digital health, AI, and innovation, and then landed my role at FU Cancer. And that's something I will talk about a little bit later. So let's dive in here. Okay, so learning objectives. Number one, describe the core components of digital health supportive care survivorship models. Two, evaluate clinical outcomes associated with digital health interventions in oncology survivorship. And then three, identify evidence-based strategies for integrating virtual survivorship tools and clinical workflows. So we all know there's millions and millions of cancer survivors, over 18 million in the United States. And the good news is that with more cutting edge treatments, people are living longer, mortality is going down, but we still have this problem. And so survivorship outcomes are shaped by inequities in access to supportive care services. And this is particularly true when it comes to racial and ethnic minorities, rural residents, and those with limited English speaking language, and lower income populations. And so, despite guideline recommendations from the NCCN, ASCO, and ACS for the three main pillars that fall in.
I'm sorry, Kelsey. I think I accidentally hit the mute on you. I meant to hit on someone
You're
else.
good. You're good. Can you hear me now?
Yes,
Okay.
sorry. I
No, you're
tried
good. You're
one
good.
of those things.
You're good. So the three main pillars that fall into the bucket of supportive care encompass nutrition, movement, and mental health. There are unfortunately multiple factors that hinder this implementation of the pillars throughout different health systems. And, we're all familiar, most, if not all, health systems these days have resource limitations, time constraints, financial barriers that impact this access to supportive care, especially those that are non-academic or not associated with an academic hospital. So what you find is that there's this inequity for those patients that aren't going to academic centers or don't have the resources or the means to seek out this care. And those individuals are falling through the cracks. And it's in this gap that digital health is hoping to close that gap. So, through the pandemic, we all had a little taste of how digital health can make an impact, and we were forced into this virtual world. And some might say that the pandemic actually even accelerated adoption of telehealth, given its ability to improve access and continuity of care. So, another piece of this puzzle when it comes to digital health is obviously technology. And ensuring that the systems that we use are secure, password protected, restricted access, have audit trails, software updates, and the highest caliber of cybersecurity. And this is a challenging piece to put in place when it comes to digital health. And usually within health systems, the technology piece is one of the rate limiting steps for implementation. So pivoting into the world of cancer survivorship, which is an all-encompassing word, but when we break it down, we're essentially looking at surveillance, symptom management, health promotion, psychosocial support, and care coordination from time of diagnosis through long-term follow-up or end of life. And we all know treatment-related symptoms can be and are chronic, debilitating, persistent, lasting well past the point of active treatment. These platforms, electronic patient-reported outcomes, and virtual reality can offer scalable, evidence-based approaches to closing these gaps. So there was a review done of about 24 studies on virtual care models for cancer survivorship that found web platforms, telephone calls, and smartphone applications were the most commonly implemented technology, focusing specifically on breast and prostate cancer as targeted diagnoses. Next, let's talk a little bit about the core components of digital health models. So electronic patient-reported outcome symptom monitoring has emerged as this cornerstone of digital survivorship care. And there's been a few landmark trials demonstrating really meaningful clinical benefit. I'm going to talk about those trials. So the first one is the PROTECT. It's a randomized trial, which was definitive study in this space published last year with about 52 community oncology practices, over 1,000 patients with metastatic cancer. And the patients were randomized to weekly electronic symptom survey management with clinician alerts. And what they found was that there was a significant prolonged time to first emergency visit with over a 6% reduction in cumulative incidence of emergency visits. And then when you look at the time span of a year, there was fewer mean visits to the ED. And the benefits also significantly favored this electronic patient-reported outcome monitoring for delayed deterioration of functional status, physical function. And this is a huge finding because we all know how important functional status is and plays a role in evaluation of treatment, continuation of treatment, and overall quality of life. And as a PM&R doc, this is especially important to me. So the patients completed over 91% of the weekly surveys, and over 91% would recommend this system to other patients. And then there was another study that was completed called the Texas Two-Step, which was an observational study in a large community oncology practice. And they found that electronic patient-reported outcome engagement reduced hospitalizations, ED visits, and the total cost of care on average by over $1,000 per member per month. And then when we think more about virtual reality, these tools can offer an immersive landscape that ultimately can decrease anxiety and improve relaxation. And there's been studies that have shown benefit in pain reduction, depression, and distress near end of life. I have been fortunate enough to have tried one of these virtual reality devices, and it's pretty wild how much of an impact they can make. I want to also talk a little bit about the differentiation between telehealth and telemedicine. So, telehealth includes synchronous video visits, telephone-based coaching, and asynchronous messaging, which can mean both clinical and non-clinical activities. So, it could be, for example, provider training or secure exchange of health information. Telemedicine includes the remote delivery of clinical services using telecommunication technologies, usually real time, two-way audio visual between clinicians and patients. And then mHealth, which is mobile health, refers to the mobile technologies like smartphones, tablets, and wearables specifically, and then different apps to support medical care and research and patient well-being. So there was a review of 59 studies that found most telehealth interventions focus on improving physical and mental aspects of quality of life. And survivors report satisfaction, noting the importance of this personalization through these devices. There was another study, a meta-analysis of 32 randomized controlled trials with over 4,700 patients in breast cancer specifically, that found electronic health interventions significantly improved quality of life, self-efficacy, distress, fatigue, and also had a high acceptability with a satisfaction between 70 to 100%. And then another meta-analysis of 20 randomized controlled trials found that they evaluated digital health therapeutics and demonstrated significant reductions in fear of cancer recurrence, depression, anxiety, and fatigue with significant improvement in quality of life. Okay, so then we're moving into the three main pillars that I will talk about in terms of mental health, physical activity, and nutrition specifically to oncology. Anxiety, depression, PTSD are all common mental health diagnoses that we know about in cancer patients, survivors, and caregivers to these patients. There was a study that you can see here done at UPenn that shows an overall trend specific to prostate cancer, which is probably not surprising to any of us. There was also a meta-analysis done of about 65 studies, over 10,000 patients, and over 1,000 caregivers that found digital psychosocial interventions effectively improved quality of life, reduced anxiety and depression. And the NCCN survivorship guidelines recommend cognitive behavioral therapy, including delivery of these digital modalities as a Category 1 intervention for distress, fear of recurrence, trauma symptoms, and insomnia in cancer survivors. And then the NCCN cancer-related fatigue guidelines also similarly recommend psychosocial interventions, including the CBT for behavioral therapy, mindfulness-based stress reduction, and psychoeducation therapies as a Category 1, noting that when these interventions are delivered, that they should be culturally specific and tailored to the needs of the patients and families along the illness trajectory. So being a PM&R physician, obviously I care a lot about physical activity and movement, and the importance of exercise in the oncology population. So physical activity is a Category 1 recommendation for cancer survivors, with the NCCN recommending at least 150 minutes of moderate intensity or 75 minutes of vigorous intensity. They also recommend wearable fitness trackers or smartphone apps to monitor the activity with specific goals a target of adults younger than 60, 8,000 to 10,000 steps a day, and for those over 60, 6,000 to 8,000 steps a day. And I believe last month's presentation also talked about the challenge trial, so I won't go into it too much, but it is a landmark study that was widely talked about at ASCO last year and demonstrated that a structured exercise program after adjuvant chemo in colorectal patients resulted in longer disease-free and overall survival compared to health education alone. And this is providing the strongest evidence to date for exercise as a survival-enhancing intervention in cancer survivorship. And then as a clinician, I find it interesting in the different challenges that patients face when thinking about performing exercise and then actually performing the action of it. And so Sloan Kettering studied this with over 600 cancer patients, included both from an academic center and community hospitals, and found that about 75% reported decreasing their activity levels, 16% maintained, and 4% increased. And barriers that they found were difficulty with motivation, that was about 67%, trouble remaining disciplined. The physical barriers with fatigue and pain from treatment also contributed to this decrease in activity. There was a study published in 2024 that was a meta-analysis of about 10 randomized controlled trials with over 800 participants that showed telehealth exercise-based cancer rehab significantly improved cardiorespiratory fitness and physical activity compared to just usual care. And then there was a 2025 meta-analysis of 15 trials that found virtual exercise interventions improved upper body strength, lower body strength, gait, pain, and fatigue. And so, we are definitely making progress when it comes to virtual physical activity and exercise in the oncology patient population. My personal perspective is that I think we still have a ways to go. So nutrition is a critical component of cancer care. Malnutrition affects up to 41% of cancer patients globally, and contributes to increased mortality, treatment toxicity, and diminished quality of life. Malnutrition in cancer results from a combination of anorexia, metabolic dysregulation, and treatment-related toxicities. And there was a study that demonstrated over 51% of patients already have nutritional deficiencies when they first go to their oncology visit. And a comprehensive meta-analysis of over 30,000 cancer patients found the overall prevalence of malnutrition to be about 41%, with severe malnutrition doubling the risk of death. So obviously this is a factor that we really need to pay attention to. Malnourished patients face a 2 to 5-fold higher mortality compared to well-nourished patients, a 3-fold increased risk of hospitalization with severe infection, and a 2.5-fold increased likelihood of treatment dose reduction or discontinuation. And then cancer cachexia is a multifactorial syndrome of involuntary weight loss, skeletal muscle wasting, and systemic inflammation that occurs in about 50% of cancer patients. It differs from just simple starvation because the tumor's metabolic reprogramming drives proteolysis, lipolysis, chronic inflammation, and this makes weight loss resistance to conventional nutritional repletion alone. So all cancer patients should undergo malnutrition screening using a validated tool at diagnosis and then regularly throughout treatment. And the NCCN Older Adult Oncology Guidelines flag unintentional weight loss greater than 5% in a month, 10% in 6 months, a BMI less than 22, or weight less than 80% of ideal body weight as triggers for further nutritional assessment. The NCCN Survivorship Guidelines recommend a predominantly nutrient-rich, plant-based dietary pattern for all cancer survivors. So this is a consistent theme across guidelines, is the need to position nutrition at the center of a multidisciplinary cancer care, integrating dietitians, exercise specialists, speech language pathologists, psychosocial support from a diagnosis through survivorship, and this early proactive nutritional management rather than just this reactive intervention after decline offers the best opportunity, to preserve functional status, improve treatment tolerance, and ultimately enhance overall survival. So there was a quality improvement project that implemented a hybrid model for on-site and virtual registered dietitians at different community cancer centers that demonstrated over 69% of 302 scheduled appointments were successfully delivered virtually with nationwide recruitment, allowing for hiring this more rare talent and improving access to nutrition care, which ultimately helped delay patients at risk for malnutrition. And there was also a survey done of both oncology providers and cancer survivors that found both groups endorse nutrition counseling and patient navigation support as an appropriate tool for telehealth delivery, with over 50% of these providers and survivors agreeing that these services could effectively be delivered virtually. Next, I'll touch on caregiver support. And this is something that we value at FU Cancer quite significantly. So caregivers shoulder substantial, often invisible burdens, managing portals, troubleshooting devices, navigating insurance, and providing care to the patient. The NCI published the following stats regarding caregivers for cancer patients, and the numbers are concerning. About 50% report high emotional stress related to caregiving. 25% report high financial strain. 50% were employed while caregiving. 72% assisted with medical tasks, and about 43 reported needing help with managing emotional and physical stress. There's a preliminary study of caregivers of patients with head and neck cancer that 6 months after diagnosis demonstrated about 20% met the criteria for PTSD. The NCCN Older Adult Oncology Guidelines recommend periodic assessment of caregiver burden using some validated tools, considering a referral to social work, respite care, or other support services. And there was a 2025 systematic review of about 35 studies that found digital health interventions, including psychoeducation and psychotherapy, delivered through online courses and websites, effectively reduced depression and anxiety symptoms among cancer caregivers. There's a cancer distress coach caregiver app pilot study that showed 81% of transplant caregivers reported clinically meaningful reductions in PTSD symptoms at 4 weeks, with significant reduction in anxiety. And then the ASCO palliative care guideline update notes that a single or multimodal interventions benefit caregivers based on their needs, location, resources, comfort level, and access to technology, with evidence showing benefits in about 3 to 4 sessions, and those benefits persist up to a year. So telehealth app-based support, virtual care options, these could all potentially allow increased access to support services for previously underserved populations. Studies focusing on disparities in digital engagement have found that younger, female, more educated, and higher income survivors are significantly more likely to use digital health tools. And older, male, less educated, and lower income survivors face persistent gaps with digital health. So when we think about some strategies to close this gap, those may include co-design approaches, meaning actively engaging patients and community stakeholders in the design of digital health interventions to enhance the usability, cultural relevance, and ultimately trust of these users. And then when we think about practical infrastructure, some options might include interpreter integrated telehealth, using plain language and digital content, device lending programs where devices are rented out, or community Wi-Fi access points. And the NCCN recommends that these interventions be culturally specific and tailored to the needs, as I said earlier. So in terms of clinical outcomes, I'm going to go back to some of the studies that I talked about before. The PROTECT trial demonstrated over a 6% reduction in cumulative incidence of emergency visits and a fewer mean visits at 12 months. The Texas two-step study showed about a 49% reduction in odds of hospitalization and over $1,000 per month cost savings. The PROTECT trial also, as I mentioned, delayed functional decline deterioration. And then across studies, patient satisfaction with virtual supportive care remains consistently high. In the PROTECT trial, about 77% felt that these electronic patient-reported outcomes actually improved discussions with the care team. 84% felt more in control of their care, and over 91%, as I said earlier, would recommend it to other patients. The Sidney Kimmel Cancer Center reported that virtual programming during COVID engaged over 3,000 participants, with 94% rating programs exceptional or very good, and 88% indicating they would attend again. So the importance of screening with electronic patient report outcomes using these validated screening tools is important, especially at key transition moments. So that would be diagnosis, treatment initiation, treatment completion, and then surveillance visits. And then the PROTECT trial demonstrated that over 91% survey completion rates are achievable in routine community oncology practice, even among patients with limited prior technology experience. And when we think about delivering integrated virtual care across the three domains that I previously mentioned, again, I just want to reiterate offering cognitive behavioral therapy, mindfulness, and the psychoeducation via video or app-based platforms can be helpful. The NCCN recommends the CBT delivered via digital modalities as a Category 1 intervention for distress, fear of recurrence, and insomnia. I talked a little bit about the physical activity importance in implementing supervised virtual exercise classes, combining both aerobic and resistance training while using a wearable for tracking. And telehealth exercise rehab significantly improves cardiorespiratory fitness and physical activity levels. And then specific to nutrition, using these virtual dietitian models has demonstrated successful delivery in over 69% of appointments virtually. And then as another core component, including caregivers as a standard practice, extending these digital tools and psychoeducation specifically to caregivers, and periodically assessing the caregiver burden using these validated tools, and offering digital interventions for depression, anxiety, and PTSD specifically. So I'd just like to mention a little bit here about FU Cancer. It's a digital supportive care platform designed to provide critical expert resources to patients and caregivers to manage treatment side effects, improve nutrition, mental health, and physical activity, and overall lifestyle behaviors. We use evidence-based guidance from time of diagnosis through advanced survivorship care. And we know that virtual survivorship programs show strong evidence of success in research and clinical practice, but they're sparingly used. And that's what we're trying to do here is leverage technology to support the gaps in clinical care by bringing experts from across the country in cancer rehab and survivorship to patients and caregivers. And we're partnering with different healthcare organizations, oncology clinics, and clinicians who want to expand their survivorship resources. We currently have an active pilot study that's free to participants if they would like to enroll. So feel free to reach out if you would like to connect. Here's all of my references. And then that's all I have, and that's my email. Feel free to reach out.
Thank you, Kelsey, so much for telling us about all this. I mean, so research backed. I mean, it's great when you have a tool like this as so evidence-based, and this is all being promoted so much more in the literature.
Yeah.
Like you said, this was definitely a jumping off from last month, listening to the exercise oncology and perfect segue into this and
I'm
talking
so glad.
about the physical activity, the nutrition,
Hmm.
mental health. That's wild that the caregivers, so many
I know.
exhibits PTSD symptoms
I
after.
know.
Oh my gosh. I
Yeah.
didn't know it was, I mean, I talk to caregivers sometimes. We talk
Sure.
in our survivorship team, speaking to
Yeah.
patients and their caregivers. It is it is hard.
Yeah.
Um,
Yeah.
so
Yeah. They often get
so
overlooked, unfortunately.
it's true. It's
Hmm.
true.
Hmm.
And we focus so much on the survivor sometimes.
Hmm. Hmm. Yeah.
So yeah, thanks
Yeah.
for talking about all this. Does anyone have any questions or comments for Kelsey? I'm going to call you out, Dr. Ganshow. This is our director of cancer prevention
Oh,
survivorship at
nice.
UNC.
Hey, Kelsey, thanks so much for your wonderful talk. It's great
Yeah.
to know there are resources unlike yours that cancer centers, right, can use because I think when it comes to supportive care, sometimes putting that all together, right, bundling that and making that
Yeah.
available. So tell me a couple things.
Hmm.
Are some of your tools integrated into the EMR, right? There's always I think I've talked
Hmm.
about this whole digital thing and offering
Hmm.
and patients trust. And when they're, a bunch of a whole lot of external platforms, sometimes patients don't trust them.
Hmm.
So could you talk a little bit about that? And then I'm glad that you sort of addressed, the fact that there are populations that don't engage in this and how we can
Yeah.
support them to engage and identifying who they are and giving them the tools to do
Yeah.
this. I like some of the solutions that you have, pitched potentially
Hmm.
um, community Wi-Fi, rental of digital devices, and if you could talk a little bit more about
Sure.
some of the details of how you've used those and what your
Yeah.
successes have been.
Yeah. So EHR integration is difficult. With a large health system too, there are so many steps. It can happen. It takes a while. So the process itself is usually pretty slow. And I think it really depends on the health system and their, cyber security and technology and all of that. Um, I do think in terms of electronic patient reported outcomes and monitoring, um, I think we're moving in that direction, and I think it's just a matter of time in the oncology population until most health systems adopt this form of monitoring. I do think, in my personal opinion, there will probably be a protocol to some extent set up on how to implement. But just given the stats and the clinical benefit, I think the health systems that don't join in on this are going to be left behind, unfortunately. Um, but it is difficult at this day and age. And then in terms of engagement, it is something that, as part of a company that is using a digital tool, we have to think about. And especially when you want to scale. Different types of options that I've seen both in literature and just through clinical experience is there is something to be said when a clinician recommends a digital tool. There is a lot of trust that comes with that. Um, Patients, I think, obviously trust their clinician, I would hope. And if a clinician is recommending that, they are more likely to seek out that tool or device. So that's one aspect of that. In terms of reaching those users and patients and caregivers that might be more rural or less savvy with technology, um, options could include using some sort of telephone-based survey approach, which has been done in the literature and successful. And then I think also doing like walkthroughs, right? So when a patient comes in that may be in a rural area, having some sort of nurse navigator or whoever it might be that is championing this tool, really just sit down and show them how to use it and make it as simple as possible. And then also making sure that the content provided in these tools are user-friendly from a language standpoint. So whether that's Spanish or French or whatever it may be, having it be available in different languages, I think helps.
Yeah, great. I think our experience here with a wide variety of populations is that it's kind of a combination of high tech and high touch, right? But that, using, because we've got navigators now across our disease teams, but
Sure.
utilizing those navigators efficiently, right? Utilizing digital technology that can take the workload off of some of our navigators, right? So that
Totally.
or, using them just as more sparingly so we can
Yeah.
most efficiently use our navigators, I think is a real goal of ours here. So,
Yeah,
um,
you have to think about it both from the patient and caregiver standpoint and then also from the health system standpoint, right? We don't want to add more work as clinicians and nurse navigators. There's a balance. Yeah.
right. We want to use everybody at sort of the top of the level with the
Yes.
patients that really need it the most, right?
Yes.
So
Yes.
really kind of figuring out who these tools are working with and who needs those maybe
Yes.
telephone based or warm touch, high
Hmm.
touch
Mm.
Yeah.
to engage them. I think make sure that nobody gets left out.
Yes. Yep.
I know, Sean, you think about this. I think Sean's on, right? I'm going to call him
I
out
think
since Debbie
so.
called
I
me.
saw him.
Give me
Hold
a
on
minute.
a minute. Betty, come on, Betty. Betty, speak up.
Let me see
I saw
some.
you in the chat.
Hi. Sorry, I'm in a busy airport. Fascinating, and I'll back up all that data that you presented. Of course, that's always a big plus. Um, I am curious about data, and I was just Googling about, you had mentioned that there are more survivorship clinics and or survivorship care and academic centers versus those
Yeah.
others, and I am looking for data to back that up.
Hmm.
Um, because I think survivorship clinics are few and far between.
Yeah.
And I work across the United States with
Sure.
a lot, so it's kind of
Sure.
crazy. And honestly, care like this, these points,
Yeah.
if all people diagnosed with cancer could have this type of care, right?
Yeah.
Then the outcomes are going to be far superior and
Hmm.
far superior for life. As you pointed out, so many people are surviving now.
Hmm.
And if you know how to eat
Hmm.
and move your body
Yeah.
and get that mental care, it's
Yeah.
going to make the latent long-term effects
Absolutely.
less and your
Hmm.
quality of life higher. So
Hmm.
kudos.
Hmm. Hmm.
Um, but how is it paid for?
The our specific app or just in general?
Your specific app. Yeah, in
So
general is
yep.
that's that we don't
I was
have
gonna
enough
say
time.
that's a big question. Yeah. So our specific app right now, so with our pilot study, it's free for patients and caregivers. And there's no limit on that right now. We're just trying to get as much data as possible. So there are surveys to fill out, but currently it's free. If someone did not want to enroll in the pilot study and just wanted to be a participant, do it at their own time and, not fill out the surveys, it is $20 a month. But our ultimate goal is to not have patients and caregivers pay for this. So we are targeting payers and health systems. Yeah, that is our long-term trajectory. We're just an earlier stage company currently. So
And so you probably don't have a ton of data on who's
correct.
actually consuming and using it, what
Correct.
age range, what
Uh-huh.
demographic.
Yeah.
Okay, great.
Yeah. Hmm.
Thanks.
Hmm.
Great stuff.
Thanks.
Yes, just comments are coming in. Thank you. This is so important, so detailed, so researched. So we're all very glad you're doing this work
Hmm.
and this important stuff out there at FU Cancer, the polarizing name.
It is a
Uh,
polarizing name. Some people love it, some people don't.
Um, Kelsey, a follow-up question to
Yeah.
Betty. Is there like a
Yeah.
business model that cancer centers have used to sort of
yeah,
invest in this and what they get
right.
back as a revenue generation, et cetera, sort of making that business case for cancer centers to take this on?
Yeah. So I would say so far, we've just done the pilot studies, and there is a business model. If you are interested, I can definitely put you in touch with Shelby, who's our founder, CEO. She is very, very well versed in the business side of this all, and what the potential revenue from a health system standpoint would look like as well.
Great.
Yeah,
Thank
Hmm.
this is something I think, yeah, Pam, this would be great to, talk to our cancer center about integrating such a tool.
Yeah.
Um,
Yeah.
it's,
I'd love to talk.
it
Yeah.
seems like a no-brainer, right? There's a lot of paperwork and a lot of integration and figuring things out, as it is at any system.
Yeah.
And I
Um,
think each institution may have, different
Definitely.
They do.
resources, right? And
They do.
different
Yeah,
needs for the
Hmm.
different tools, depending on kind of what their supportive care resources are.
That's
So,
exactly true.
yeah,
That is what
and
we
not
found.
just
Hmm.
at the university itself or the health center itself, but the community as
Hmm.
well. Like
Hmm.
some communities have a rich like physical rehab
Hmm.
program, but
Yeah.
other places, may be more sparse, like you say,
Hmm.
getting into like rural areas. How
Yeah.
do
And
you like market this out to health centers, health
yeah.
systems, people? Is it just a website?
Oh, how we're marketing currently. It's a lot of presentations, it's a lot of conferences. We are currently in the Cancer X Accelerator out of Moffitt Cancer Center.
Oh,
Um, and so we have different champion companies that we're working with, health systems that are supporting us as well. So it's a step-by-step process, but it is a lot of legwork.
for sure. For
So
sure. As yeah, startups. When did FU Cancer come into inception? You said
yeah,
it's kind of a baby.
yeah, the company, Shelby started the company over just over a year ago, and our
Mhm.
MVP came out last November.
Wow.
So,
So
yep.
real
Mhm.
baby, baby.
Baby, but making significant strides, which we're really excited about.
That's fantastic.
Yeah.
So, and yeah, you speak all over the country,
Hmm.
obviously, for
Hmm.
anything. So anyone here, if you want to hook up with Kelsey or Shelby
Yeah.
to get a talk at your institution, I'm sure
Yeah,
Kelsey is
absolutely.
totally willing to do that.
Yeah.
We are
And
happy to.
I will say too, Shelby and I are a good match because she actually is she has her PhD in oncology, clinical nutrition. So we bring
Okay,
two
perfect.
different aspects, but really, really needed to the cancer
Yeah,
patient population. Yeah.
cover that.
Hmm.
Yeah, for sure. Yeah, we work a lot with a community organization, Wellness House, and
Okay.
they are very focused on mental health,
Okay.
nutrition, activity.
Okay.
Um, so that is, oh, Caprina wants a talk
Sure.
for New Jersey
Hmm. I'll just
nurses. So
put in my email here so people can reach out to me.
perfect. Yes. So Caprina, write that down. Uh, and I'll make sure I CC you on the email. I send out a recap, and this will
Okay.
be a recording we'll put up
Okay.
on our YouTube. So we really appreciate you coming.
No, thank you for
Does
having
anyone
me.
else have any other questions for Kelsey while we have her? This has been a great talk and, great resource. We need more resources like this for our
Yeah,
survivors,
I
right?
would agree. I would agree.
Really to help to bring together all that care
Yeah.
because we know this improves outcomes.
Hmm.
We've seen this,
Hmm.
we all have.
Yeah.
And so I mean, it's great work that you're doing to
Oh, thank
put
you.
it and implement this for
Yeah.
sure.
Yeah.
I'm glad, very glad we got you to
Hmm.
talk.
Hmm.
All right. Well, like I say again, I'll send out a recap once I
Sounds
get the
good.
recording up,
Okay.
and we'll be in touch, Kelsey.
Sounds great. Okay. Thank you.
thanks so
Thank,
much, Kelsey.
Bye.
Great talk. All right, bye.
thanks all for coming. All right, have a great weekend.